We all,
Please,
I think we are Facebook friends.
yes, ma'am. Yes, ma'am.
Yes, sir.
I'm not on Facebook. We are going to be friends only on Zoom and WhatsApp.
Yes,
Right?
yes, madam.
I hope we can start now. We have 24 participants as of now.
Yes, yes, yes. Start.
Okay.
Good evening, everyone. As you know that we are organizing the 13th webinar for Academy of Pain Physiatrists, and we are very, very lucky to have here a very young and dynamic pain physician here. She is Dr. Smruti Hota. If I'm pronouncing it right, just let me know. She is the director and consultant at Pain Specialist at Relief Pain and Spine Center at Sambalpur, and you can just imagine her credentials in her archery by knowing that she is a faculty at the Radariya Pain Clinic. She also won a Young Pain Physician Award at AMP, and there are a lot of things that could add to her credentials, but I really am very small to say something in front of her. She is going to address a very, very important issue which we just overlook because we tend to learn a lot of pain procedures, but we don't want to learn what are the complications we can come across when we are doing some pain interventions. And this incredible topic is being covered by her. Over to you, ma'am. And just before we start, one more thing. Today is 13th webinar, and we are doing it on Friday evening according to Western standards. It is Friday the 13th, but yes, we are going to start on a very happy note. Over to you, ma'am, please.
Thank you so much, ma'am, for your kind uh, introduction about me. And I'm really grateful and honored to be speaking with you today. And so without any delay, I want to start. So I'm sharing my screen. Today, I will be speaking about the common complications of the pain interventions and their management. So I hope my screen is visible, ma'am.
Yes, it is visible.
Okay, sir. And I think I'm audible.
Yes, ma'am. You are audible.
Okay, sir. So today we will be discussing about the common complications of the different interventions and how to prevent and manage the complications. So today's agenda is to understand the common complications that is associated with pain procedures and how to recognize the high risk scenarios and patient factors also, and to learn the practical prevention strategies and review the evidence-based management protocols we always follow, that has been evidence-based. So we will discuss one by one, and I will start from head and neck and up to the sacrum and few ultrasound guided intervention complications, and these are for both USG and CR. And as you know that nowadays, as we are in 21st century and pain medicine is evolving every day, we are dependent on the CR and ultrasound as our it's like a stethoscope for us. And nowadays, almost blind techniques are obsolete because of this complication. And so we will start with head and neck intervention. These are few common interventions in the head and neck area, like we will be doing in our routine OPD, routine OTs, like interlaminar cervical epidural injection, intra-articular facet joint block, cervical medial branch block, and radiofrequency ablation. And pterygopalatine or sphenopalatine ganglion block, radiofrequency ablation, stellate ganglion block, which can be performed nowadays. CRM guidance is almost obsolete. We prefer in doing it under ultrasound guidance. Then trigeminal ganglion block or radiofrequency ablation or percutaneous balloon compression. I will start with the cervical epidural. Cervical epidural is a very common procedure performed mainly when it is indicated, especially any cervical discogenic pain or any cervical radiculopathy or other sometimes in cervicogenic headaches also, or any nerve root compression. So here, the first complications that I will discuss is the dura puncture. And as we are very familiar to the word post-dural puncture headache, PDPH, and many of us have seen this headache, but so imagine if you are injecting intrathecally. So what will happen? There will be sudden onset of motor block and apnea, even death. And here, so to avoid these complications, always we should aspirate and observe the injected pattern under fluoroscopy or ultrasound guidance. CSF flashback changes everything. We can't do anything. Once you see the CSF, stop the procedure. So many a time people ask, once you see the CSF, once there is a dura puncture in cervical epidural, so what is the next? Just abandon the procedure. Don't proceed with the same epidural. It's my suggestion. Then the second is the subdural puncture. So subdural puncture is though rare, but it is very dangerous. It always presents late. There is a delayed presentation. And sometimes it is the patchy blocks, and then out of nowhere, a cardiopulmonary collapse will be occurring. And subdural space can trick even the seasoned hands. So it can happen with anyone. Or even if you are an expert pain interventionist, but we should be careful about this complication, though it is rare. And another is the epidural blood vessels. Here, especially epidural blood vessels injury is very common in elderly. When in our routine practice, when you are doing this, performing this procedure in older individuals, and they have, and especially those who are on anticoagulant therapy. So even you are a millimeter off, then and you are in a vessels, the bleeding here doesn't mean bruising, because it here bleeding means paraplegia or due to hematoma. It's not due to bleeding, it's due to hematoma, and it may not present during the procedure. Patient may come back from the OT work and will lie on the bed, but it will come back after 12 hours of the procedure. It may come. Then another complication of cervical epidural is direct spinal cord injury. That is the ultimate nightmare of the all of us, especially with the cervical or thoracic procedure. That's why to avoid this complication, we use, see, this is very common procedure. Earlier it was because previously people performed this procedure in blind technique. Blind epidurals were in the 90s. There are a lot of papers also has come that has been shown that this complication is common with blind procedure. So nowadays it is rare just because we are using ultrasound, UCM guidance or USG guidance. Any doubt? Okay. So next complication is infection. Pain patients are vulnerable because, maybe due to our negligence, or maybe patient is immunocompromised like diabetic, or he or she had previous any infections, or they have poor skin hygienic. It is not just abscess, it is a maybe this infection lead to abscess. Sometimes it may lead to dreaded complications like osteomyelitis. So you before you are putting any needle, and in the head and neck, any interventions you are doing, remember you should uh, like prepare everything with proper aseptic precaution, because think of as if we are entering into the brain. Next is the anticoagulant, and many interventions gone wrong were perfect except for the patient was on Apexa 1 and the 9. So remember, you should protocol the ASRA guidelines.
I'm studying. मैं स्टडी कर रही हूँ, रोने की आवाज नहीं आ रही है.
Please unmute whoever is having those
Yeah,
disturbances.
kindly mute, please, so
Please.
we can discuss more effectively. Okay, so anticoagulant should be avoided, or it should be stopped according to the ASRA guidelines. And then what is anticoagulant? Then avoid heavy sedation. Usually this cervical epidural procedure always try to avoid sedation. And these are few symptoms like post-procedural pain, vasovagal attack, so allergic reaction. These are common to all the pain procedures. Next is cervical facet block. The cervical facet is, though it is very superficial block, it is very superficial structures that we can easy. It seems to be easy, but the main culprit here comes the vertebral artery. If you remember the structure of the cervical vertebrae, mainly is the cervical vertebrae. You have seen how the foramen are oriented with the cervical facet. So the vertebral artery here, it waves through the transverse foramina from C6 to C1, and its anterior is the target. But just one misjudged trajectory can lead to intravascular injection, and the result is seizure. Yes, seizure from local anesthetic in the vertebrobasilar system. So every time, one more thing I will remind, that when we are injecting something into the head and neck area, two things we need to remember. One is we should not use particulate steroid. Always prefer a soluble steroid like dexamethasone, and another one is your local anesthesia. Lignocaine should be, if we are using, because I use lignocaine in my practice, and lignocaine should be preservative free, totally preservative free, because these are lignocaine itself is not doesn't cause seizure. The seizure is mainly caused by the preservative, that is the methyl paraben is the main culprit. And here, always use contrast and real-time imaging to avoid this kind of complication. If we are injecting contrast into the vertebral artery, then nothing will happen. But you should avoid, because we can't say nothing will happen, because rupturing a artery that is entering into the brain itself is dangerous. And yes, and one more thing, vertebral artery is not same in every individual. Lot of anatomical variations is seen, and that's why it is assumed that you are not where it expect to be. So accordingly, very precise and meticulous needle entry is mandatory for these procedures. And another culprit is your ascending cervical artery, that is the feeding artery to vertebral artery. And once it is here, it is very the result is your embolism. Embolism is the major posterior stroke or ischemic injury. That is not a complication, because it many catastrophes. It will change the whole patient's life. So this, and another three critical space you should remember: epidural, subdural, and intrathecal. Especially in the lateral approach, it is dangerously close to violating this compartment, because we are most of the time this facet block, we use posterior, one is posterior approach and one is lateral approach. Though posterior approach is little easier, trickier, and it will need a longer needle, and lateral approach will be very nearby the structure, but lateral approach is more dangerous, because these three space are more closer in the lateral approach. So another is your lung nearby cervical facet, upper apex of the lung. There is a chance of pneumothorax at C5, C6, especially the apex of the lung lies. So it is the neighbor of these two vertebra. So even slightly medial trajectory, you may lead to rupture the pleura and leading to pneumothorax. So there should not be no lateral blind, like not go blindly. And here use oblique fluoroscopy guidance. Epilateral checking is mandatory, even with inches of the needle entry. So exiting nerve root, again, exiting nerve root will be lying directly nearby the facet joint. So even direct trauma, or if we are injecting the high volume of the drug, then also it will injure them. And that's why when you are entering into the this facet, and if you are hitting the bone, and then you are, after hitting, just slightly remove the needle, just slightly 1 millimeter, and injecting, if you find something hard and your drug is not going, then don't push it. Maybe we are injecting into some nerves, So we have to be very careful. Then next is cervical medial branch. These are two areas, and almost complications are same. Again, the same ascending cervical artery. It will be like feeding artery to vertebral artery. Chances of embolism is there also here. So again, we have to be very careful. And another artery here comes is the radicular artery. Here, radicular artery occlusion, what it does? Radicular artery occlusion causes the spinal cord ischemia. Especially, it is a very common complication when we are doing medial branch block at the middle or lower cervical levels. And suppose we use particular steroid, then patient is gone if it has entered into the radicular artery, because it may lead to anterior spinal artery syndrome. So always aspirate, use minimal volume. So how much volume we used to give for cervical medial branch block? Only 0.5 to 1 ml, not more than that. And for diagnostic, only 0.3 ml. This much injected we need to inject for the block. And for the treatment purpose, it's 0.5 to 1 maximum, not more than that. And then exiting nerve root, that is the exiting nerve root, but here there is a high chance of damaging the exiting nerve root, because the medial branch and exiting nerve root are only few millimeter away from the each other. And if, even a misdirected needle, a forceful injected, or even a just light anatomical variations, there will be a pain, not relief. If we are hitting, injuring exiting nerve root, imagine there will be same kind of radicular pain, and all the symptom of neuritis will occur. So to avoid this exiting nerve root injury, one thing we can do, that always try to put your needle under tunnel vision in fluoroscopy, or in plane technique under ultrasound guidance, not outer plane, and no blind needling. And in fluoroscopy, try to watch contrast spread. If you see radicular flow, if along the direction of the exiting nerve root, then stop injecting or abandon the procedure. And these are also common, like intrathecal space. If it has entered, then death, paralysis, spinal cord ischemia, epidural anesthesia. These are the common complications for both the procedures. Then coming to spinopalatine block, one of the most difficult block that I have faced, but books always write that this is the easy, but it has never been easy for us, because here each millimeter matters. Okay, then the spinopalatine ganglion, you have seen the how it is lying in the pterygopalatine fossa, how the V2 maxillary division comes out through the fissure, and the pterygopalatine ganglion hangs down from the maxillary nerve into the pterygopalatine fossa. And I hope you know the anatomy, so I'm not discussing. And here the spinopalatine ganglion, especially when we perform transnasally, it is easier, but we do not prefer that under fluoroscopic guidance. We use either through the between the two coronoid process of the mandible. And here one more thing, very common complication occur is because face is highly vascular, so there is a chance of injuring the epiphyseal vasculature, that will lead to local hematoma or retrobulbar hematoma. So once bleeding start, there will be through the inferior orbital fissure, the blood can track into retroorbitally. That may lead to proptosis, vision changes, and even orbital compartment syndrome. And so always try to avoid deep or forceful needle advancement. Even if it is through the between the two coronoid process of coronoid and condylar process, you can go through that space. Here also avoid, and even we are going transnasally or transorally also, we should avoid this, or that is called the infrazygomatic approach also, and try to aspirate the needle. And always use gentle pressure, because I know many a times, even if we do not want, inadvertently some pressure we try to put to advance the needle, so that we should not do. We should avoid. Then coming to the spinopalatine and maxillary artery, we know these are the artery that are lie dangerously close to our path, our needle path, our target. So here sometimes anatomical variation may happen here, so that lead to, and this artery has communication with the internal carotid artery via the Vedian artery or pterygoid, Vedian or pterygoid canals. So to avoid any injury to the artery or embolism, here simple here also, and avoid the particular steroid, use soluble steroid. And always image guidance. For spinopalatine ganglion block especially, it is a block performed in the lateral view, not epi view. Epi view, we should check in the end middle position. And the maxillary nerve, that is the it hangs the this ganglion into the fossa, and it exits from foramen rotundum, and injury or inflammation here can cause dysesthesia in the palate, maxilla, and pharynx, posterior pharynx. And another is your, its sub branches are also there. Maxillary nerve has many branches like posterior superior alveolar nerve that has that innervates the teeth, upper teeth, and your nasopalatine nerve that will go to the nasal septum and nose and hard palate also, and the greater and lesser palatine nerve to the soft or hard palate, and the infraorbital nerve. This is one of the important branch that will supply the cheek, upper lip, and lower eyelid. And they are always, they will, these things, these poor nerves will always come into your path. So here, aggressive radiofrequency ablation or poor needle trajectory is a big no, because it may either result in your facial numbness or altered taste or speech. So we should be very careful. Another is lateral nasal wall and mucosa. There will be like it, these are the entry point for infections. So to prevent, always prepare antiseptic nasal spray before starting the procedure. Nasal cavity should be sterilized, and cautiously advance the applicator and needle also, and also educate the patient. Patient education is very important, otherwise a post procedure patient will be very much scared after, like if you will any anesthesia or anything, or post nasal block. Even educate the patient about the post block nasal hygiene. Even after the procedure, he should maintain the hygiene of the nose. And then parasympathetic chain also there. The vasovagal and autonomic effect will also come. We know that spinopalatine ganglion is a parasympathetic hub. So it's no surprise that you may get vasovagal reaction. And some patients also report there is temporary eye dryness post block or post radiofrequency ablation, especially if the ganglion fibers to the lacrimal glands are affected. Always inform the patient that such symptoms may occur, and they usually temporary and self-limiting. So these are the very common complications that I have been discussing, and evidence has also been shown in many articles that these complications occurs, and it happens also. And it's no wonder that if we are performing this procedure, we may also face this type of challenges. Then coming to stellate ganglion block. Stellate ganglion block, that is why we use it for any complex regional pain syndrome of upper limb, or any other the vascular disease like arterial occlusive disease, Raynaud's phenomenon. These are the indications, and it is a very now effective and fruitful. This procedure is truly rewarding procedures, and but the complications are equally dangerous. And here the first is the carotid artery that we know when we put our ultrasound probe for stellate ganglion block, one pulsating artery we see under ultrasound, and that is the carotid artery, and that is the stroke zone. That I flag it as a stroke zone because this is the most anterior obstacle. Even in unintentional injection here will lead to seizure, stroke, dissection, and catastrophic bleeding. And always use ultrasound. That's why I will personally advise to not to use fluoroscopy for this procedure. Ultrasound is far more safer because we are not able to see the vasculature under C-arm, and even if we are separating in our hand, but still we are not sure where we are landing. So the ultrasound guidance, this carotid artery, if you are doing meticulously, if you can visualize your needle, you will never touch this artery also. And the next is the jugular vein. It is you most of the time what happens, jugular vein is compressed under ultrasound. When you put the pressure, the probe will compress this vein and it can disappear on the screen. So if you hit the compressed vessel, it can bleed. So be careful. We don't put much pressure over this jugular vein, and watch your needle path, especially in hypotensive or hypovolemic patient. Also, sometimes this jugular vein remain collapsed. Then nerve injury are very common. Another because here these are the nerves, they supply vocal cord, diaphragm, and heart, the three vital things. And the nerves lying here will be recurrent laryngeal nerve. Injury can lead to vocal cord paralysis, especially in patients who are having contralateral nerve injury. This can be life threatening also. And vagus nerve, here stimulation or injury can cause bradycardia, hypotension. We all know the vasovagal. And phrenic component, here it will lead to hemidiaphragmatic paralysis. That's why remember, stellate ganglion block is never performed bilaterally, never performed. Always, even if it is performed unilaterally. And in a healthy person or minor or in COPD, you could remember it may lead to respiratory distress also, even if unilateral. So they should be evaluating the patients properly. Then thyroid and trachea, always bleeding and airway risks are there with this block. Needle trauma to the thyroid can lead to hematoma formation, and that hematoma will compress our airway. So tracheal puncture, though rare, can cause coughing or air embolism if we are too deep or too anterior. Another dangerous thing is the esophagus. Esophagus, especially when we approach from the left side, a needle drift can perforate or irritate the esophagus. That may lead to your infections, mediastinitis, or post-procedural dysphagia. Another important structure is the brachial plexus. Brachial plexus, what happened if we are intending to block the stellate ganglion, and we are blocking the brachial plexus, then it becomes more over somatic rather than sympathetic block. And when it happens, when our needle is going too lateral and we are not doing a sympathetic block, and that will numb your arm, there will be motor loss, and patient also want to understand what he has come for and what he landed. Then coming to the vertebral artery, and here one thing is at what level stellate ganglion block is performed under USG guidance. It usually C6 because of this dangerous thing at C7. So at C6, vertebral artery is protected. That's why we always prefer to do stellate ganglion block in the C6, and it is tucked behind the bone. But at the C7, it is vulnerable, often exposed and unshieldable. There is nothing. In 10% patient, vertebral artery also enters higher at C3 to C5. So even safe level might surprise you, because if this thing will happen. Then coming to neural and pulmonary risk, dural sleeve, exiting nerve root. So inject too medially, then you can enter into the spinal or epidural space. And once you enter spinal epidural space, there will be respiratory depression and hypotension. Exitive nerve roots, there is a direct trauma, may lead to burning dysesthesia or even motor loss. And pleura on apex of the lungs, especially when at C7, needle may step away from lung, and that may lead to pneumothorax. Discitis also not rare, can say rare, but it is if needle is in wrong tunnel, injecting too deeply into the disc may lead to discitis. It is rare but painful and very dreaded complication. Once discitis may end up with long-term antibiotics and may need surgery also.
Sorry to interrupt you, ma'am. I guess your screen is not moving. Hello.
Yes.
The screen
Is
is
there
not.
any problem?
I think the screen is not
Okay,
moving.
we are there in stellate ganglion block. Now I am
Only,
changing. Okay. Yeah.
yeah. This
Yeah.
it was
Okay.
not
Okay.
visible.
Yeah.
Okay.
Yeah. So should I repeat or?
No, we heard it, but it was not visible. That's
Okay.
why.
Okay, ma'am. Okay. Thank you. Then coming to Gasserian ganglion block. Gasserian ganglion block, trigeminal ganglion, it is the Gasserian ganglion block, one of the most important, powerful tool for trigeminal neuralgia, and it is the very rewarding procedures and also for any cancer pain, facial neuralgias. But here also there are many complications, and here, the brainstem anesthesia is the one of the dreaded complications, and most dreaded complication we can say here initially if local anesthetic reaches the brainstem, then what happens? It will signs begin to subtly become. First sign will be nausea, then sweating, then vertigo, and but it can escalate quickly to horizontal nystagmus, ataxia, and full-blown respiratory arrest. So here for Gasserian ganglion block especially, we use very small amount of test dose, and aspiration is non-negotiable here. Always be prepared with airway management and resuscitation. This is a procedure where we need full preparation in the OT. And then arterial injury, if they are here we can damage intracerebral hemorrhage or retrobulbar hematoma, both are potentially devastating. And there are petrous bone and cleavers also there. So that is our target, junction of cleavers and petrous bone. And it may lead to the cerebral cortex injury also. And overshoot, if there is angulation, if angulation is not proper, then we may enter into the cerebral cortex. And what I remember, this trigeminal ganglion is surrounded by many vital structures. We know that it's a cavernous sinus is there, medulla is cavernous sinus is there, so cerebral cortex is there. So these are the and another the nerve branches are there like petros lesser petrosal nerves. So here if we injure the lesser petrosal nerve, there will be crocodile tear syndrome, tearing during eating will happen, and cranial nerve 3, 4, 6. Here it will be palsy of oculomotor, trochlear, and abducens nerves that may lead to diplopia, ptosis, or eye deviation. Another is masseter weakness. Masseter weakness, there will be trismus or chewing difficulties due to mandibular branch trauma. And then corneal anesthesia that will lead to keratitis, that will lead to blindness, and loss of blink reflex can expose the cornea to drying and injury. So you always warn your patient about the eye care post procedure if any sensory loss is suspected. Then other critical risk like anesthesia dolorosa. This is the worst case paradox. Here, complete numbness with constant pain. It is devastating and life altering complication also. Another is dural AV fistula. It is rare, but it has been reported in 1 or 2 studies where it has been shown that a pulse tract into the dura can lead to abnormal vascular connections. Then come to meningitis. This is an intracranial route, so sterility is not an optional, it is a survival skill. And other local puncture, local complication like check the puncture, pain and hematoma, even superficial errors hurts the patient's trust. So always mark, prepare, and gently enter into the space. And here also, this is a procedure that we can't do under ultrasound guidance. Completely see fluoroscopy guidance or CT guidance we need, because we are going inside, deep inside the brain through the foramen ovale. So here there are few management protocols. I have already discussed the preventive measures. Now for management, if you are seeing some brainstem anesthesia, then stop injecting. Always keep ready the airway support, intubations, trolley, and everything. If there is an intercranial hemorrhage, ask for a neurosurgery backup. And cranial nerve palsies, then give reassurance to the patients. It is usually temporary, but if it persists, then send them to ophthalmology. Same with corneal anesthesia. Ask the patient to use lubricant or protective eye wear. And if there is anesthesia dolorosa, we can't help. Only we can use the neuropathic medications like pregabalin, gabapentin, and counseling, neurosurgery if it is refractory. Then come meningitis, use broad spectrum antibiotic, lumbar puncture, admit for observations in your hospital setting. Then if there is a facial hematoma, ask for ice pack, analgesia. It's rarely need intervention. And if there is crocodile tear, it is usually benign. Inform your patient. And if retrobulbar hematoma, then send for ophthalmologist consultation. Facial numbness, then reassure. It is also self-limiting and it will be go up. If for short duration, you can start gabapentin or pregabalin. If there is an epistaxis, then you can anterior packing or you can take help from the ENT consultants. Infections, then start empiric antibiotic. And if there is some, this is common in spinopalatine ganglion block. If there is vasovagal reaction, then we know Trendelenburg Burke position will help. Fluids, atropine if there is symptomatic. Allergic reactions, keep ready. Antihistamines, steroids, epinephrine, and airway support if anaphylactic. And dry eye, we can use artificial tears. If there is palatal numbness or dysphagia, we can avoid hot foods, and these are also transient complications. If there is a dura puncture or spinal headache, then ask them for bed rest, hydration, caffeine, epidural blood patch if persistent. Intrathecal injection, then that is an ICU care. We just support the airway, start vasopressor, send to ICU. Subdural injection, then you give supportive care, airway protection, MRI you can confirm. Epidural hematoma also send for neurosurgery consultation. Direct spinal cord injection, stop injection. This is a high dose steroid may be considered, but it's a ask neurosurgery help. Infection also you can start blood culture. You can start IV antibiotics and surgical drainage if needed. If there is any abscess and nerve root injury, stop the procedure. Short course of steroid, neuropathic medication, and monitor symptoms. Nothing to be done. It will gradually recover. Then procedure on anticoagulant patient that we have already discussed. We have to follow the ASRA guideline. And heavy sedation, masking signs like avoid deep sedation, maintain verbal communication, and monitor vitals closely. And almost we have discussed vocal cord paralysis also observed that usually resolved. Bradycardia, hypotension will already discuss. Dyspnea, if there is any dyspnea or phrenic nerve block, we can give supportive care or oxygen. Pneumothorax, we can do a urgent chest x-ray, and you can, if chest surgeon can put a chest tube, then it will be okay. And epidural and spinal block also need airway. Most of the procedure they need this one. And vasopressors, ICU support, and airway support. So we have to keep ready everything. Then coming to the thoracic procedures. The first is your intercostal nerve block. Intercostal nerve blocks, earlier it was under fluoro guidance. Nowadays we are completely doing under USG guidance because we know the many vital structures that we will discuss one by one. Most important is the pleura and the lungs and the pneumothorax risk. So most feared complications and is the pneumothorax. Even if you enter 1 extra millimeter deep, your needle will puncture the pleura. Lung will collapse. So never aim perpendicular to the rib. We always work off the rib. Use a tangential angulation under ultrasound. And post-procedure, ask the patient if there is any chest tightness or dyspnea and get a chest x-ray done. Don't wait anyone to come. And then intercostal neurovascular bundle. There may be a chance of injury. As we know, the nerve, artery, and vein run together in the subcostal group. And vein is the most superior nerve. Vein is most superior and nerve is the most inferior thing. So an unintentional vascular injection may lead to local anesthetic systemic toxicity. So that's why while injecting under ultrasound guidance, we do not need any dye. Under fluoro guidance, we may need dye. Dye should spread along the lower border of the rib. And ultrasound guidance, you try to aspirate and slowly inject with fractionated dosing and monitor the patient and keep intralipid ready for local anesthetic systemic toxicity. And medial spread, what it will do? It will do the neuraxial blockade. If your injected travel medially, then especially multiple levels or large volume, it can enter the paravertebral space also or epidural space. And that will cause hypotension, motor block, or more likely in thin patients or those who have their facial planes altered, like previously due to any surgery or trauma. So in these cases, we have to take care. And another important rewarding procedure is thoracic splanchnic nerve block, because these are the procedures that will be helpful in managing the cancer pain, upper abdominal cancer pain, pancreatitis, and other pain syndrome also. And here, this is a very deep block, so we have to be prepared with the complications also. And thoracic nerve root injury are very common. If direct trauma to the thoracic nerve root, it may lead to dermatomal pain, paresthesia, and motor dysfunction. And unlike limbs, this nerve serves the chest wall and anatomic autonomic balance. You may not notice the deficit until it is late. So to avoid this thoracic nerve root damage, we use beveled needle. Here, blunt tip needle, and do not force them against resistance. So always, this is one of the awake procedure. So we always ask patients feedback. So how is feeling? So this is a totally awake procedure, no sedation. And intercostal vessels and nerves, their injury here has a double jeopardy: nerve damage along with vascular trauma. Both occur simultaneously. Bleeding may not be visible externally, but retropleural hematoma can be catastrophic. And that's why ultrasound or contrast should be given. Ultrasound guidance, we will aspirate. CRM guidance, we can use contrast. And aspirate, inject gradually, incrementally, fractional doses we can give. Then intervertebral disc will come in between. And again, discitis is a complication, already I have discussed. Then lung and pleura, same. Intercostal, any thoracic procedure, this complication is very common. Pneumothorax risk. And thoracic duct is rare injury. It is but disastrous. Injury to the thoracic duct can result in chylothorax, a lymph-filled pleural effusion that compromises the breathing and nutrition also. And this is very common on the left-sided procedure. So in the left side, try to avoid medial deep path near T5 to T8 unless you have CT or CM. So another important structure is your aorta and inferior vena cava. Here, the great vessels lie just anterior to the vertebral bodies, exactly where the splanchnic nerve block targets lie. An error here could lead to intravascular injection. Again, same hemorrhage, local anesthetic toxicity. So always be aware of the depth. Why? How to be aware of the depth? Turn AP, lateral, CR. Make AP, make lateral, and every inches of needle advance, you need one AP view, one lateral view. So that we need to remember. Then segmental artery and artery of Adam Kiwis. These are the artery of Adam Kiwis. We know this is a key feeder to spinal cord. And if we inject any steroid or local anesthesia, it may lead to paraplegia or spinal cord ischemia. So that we have to be very careful. Then coming to the T2, T3 sympathetic block or thoracic sympathetic block. This is a block used when stellate ganglion block fails. And these are the here you when we use for this is same indication is same for stellate ganglion and T2, T3 sympathetic ganglion. Again, here lungs is an important structures lying here. Pneumothorax, again, it is the same complication. And again, intercostal bundle like vein, artery, and nerve. This may injure. Another is exiting nerve root, especially exiting nerves at T2, T3 are very small and critical, because if you have seen the thoracic vertebral arrangement, you can imagine how it is. It is more likely more like cervical nerve roots, and that's why even minor trauma can lead to intercostal neuralgia or sensory motor dysfunction. Then intraspinal structures like epidural, spinal entry, if it is go to epidural or subarachnoid space, then it may lead to apnea, same complications. Another important thing comes here is the azygos vein. Azygos vein, it lies just adjacent to the vertebral column on the right side. And puncture here can lead to internal bleeding, especially if unrecognized. So we have to check our laterality. On the right, beware of the azygos. On the left, be aware of thoracic duct. A thoracic duct injury here lead to chylothorax. A lymph-rich pleural effusion, difficult to manage, but here duct crosses the left around T5 to T6, but it is vulnerable even at T2, T3 level during deep medial needle passes. And another important, esophagus, trachea, and vagus nerve. Already I have discussed, so no need to waste time. And next is another is nerve root injury also we can expect. And these are the management protocols. Any thoracic procedures, we have to follow this. For pneumothorax, we have discussed chest X-ray, oxygen, any vascular injection, then pressure, monitor vitals, and surgical referral. If spinal block, airway support. Chylothorax, you have to do a chest imaging and thoracic surgery consult and also dietary support. And if there is vagal response, then fluid and atropine will help. Esophageal injury in antibiotic if infection suspected. Radicular pain, same here also, like cervical. Also stop the procedure immediately, consider steroid and monitor the over time. Then coming to the common lumbar procedures. Lumbar procedures is, we know, very common are the lumbar facet intraarticular, lumbar medial branch block, radiofrequency ablation, lumbar rami communicants block and radiofrequency ablation, lumbar sympathetic, lumbar transforaminal epidural, lumbar discography. Discography, though it is nowadays not done, or it's almost obsolete, but still it will help you to identify the painful disc. So with the lumbar facet medial branch block, here usually the main is your bony surface is there, so there is a chance of bleeding and sliding of the superior articular process, possibility of the nerve root damage. So what will happen if you are too medial or too deep, then we may hit and then hitting the exiting nerve roots or dorsal or ventral nerve root. And there will be a sudden paresthesia, shooting pain, even sensory or motor deficit along the direction of the nerve. So if the patient reports shock-like sensation and you are advancing the needle, then stop immediately. Reposition the needle and always inject under live imaging if possible, especially at the level of L5 S1, because I have faced the same problem. Every time when I do this lumbar facet, I always use the continuous mode of CM and fluoroscopy. Discitis is also another complication, sorry. Discitis, if you need drip, here also complications are almost same. And we should avoid entering too deep. So depth perception through lateral view, epilateral, we can change and see. Dura puncture, every epidural, subdural, intrathecal space, these are also, there may be, this is rare because lumbar facet, lumbar vertebra, these complications are rare because this the anatomy, if you have seen the lumbar vertebra, there is a large space, this lumbar vertebra is bigger than thoracic and cervical. So this is very rare, but vascular injury are also common in these cases, like if you are injuring the artery of Adam Cuvis, spinal cord injury will happen, like as I have discussed earlier. Then coming to lumbar rami communicants block. Rami communicants block is a crucial tool for any visceral, pelvic, and lower abdominal pain patients. Also, what we use for the patients who are having wedge compression fracture of the vertebra also, and it will help in acute pain relief. So this block here, but the bowel is anterior to the vertebral body, and a needle passed too far anterior or with incorrect angulation can lead to bowel perforation, and that will lead to pneumoperitoneum, peritonitis, or sepsis. Always visualize the path. Kidney, in the upper lumbar level, kidneys are the dangerously close, particularly on the left side. So a medial or posterior sweep can breach the renal capsule, leading to bleeding hematoma. So avoid overly lateral or inferior angulation or the L1, L2. Another is segmental artery. and artery of Adam-Lewis. Perhaps the greatest invisibility risk is segmental artery because it may arise anywhere from T4 to L2. So everywhere there is a risk of accidental intravascular injection or embolization. Aorta and IVC also there, inferior vena cava, there will be massive bleeding, intravascular injection also, and exiting nerve root, the pain. Here also you try to give dye and check the spread of the drug. Another important structures lying here is the genitofemoral nerve that may lead to testicular pain and groin dysesthesia if injured in male patients. So maybe you have to counsel about this to the patients. And intraspinal spread will lead to motor block, hypotension. So these are the complications. Then coming to this lumbar sympathetic block. Lumbar sympathetic block, here also complications are almost same. Intraspinal structure, same genitofemoral nerve injury, discitis, kidney injury, ureter will come here, and then inferior vena cava injury and epidural venous plexus injury may lead to your bleeding, segmental artery bleeding, that I am not going to repeat. Then coming to lumbar transforaminal block, these are also common complications. Then coming to sacral or pelvic procedures. Sacral, we do caudal epidural, superior hypogastric, then S1 selective nerve root and sacroiliac joint injection. These are few procedures that we perform for caudal epidural. Here, there is a high chance that caudal injections may accidentally enter into the subdural space that will lead to delayed onset spinal block. Again, numbness, hypotension, this will be happening. Delayed bilateral symptom, then you suspect subdural spread. So test dose with close hemodynamic monitoring is critical here. Then intrathecal injection, if needle or catheter breaches the dura and local anesthetic enter the intrathecal space, it may lead to total spinal block. Though dura ends at the level of S1, but in 10% cases, it ends at the level of S2, S3. Up to 10% in extend up to S2, S3. So never assume safety just below the L5. Anywhere it can end, and it is not your fault if dura puncture happened due to anatomic deformity. Epidural venous plexus, here caudal epidural, we most of the time intravascular injections happen, so we have to very careful. When you check under CRM guidance, you can see the vascular uptake, stop there and reposition the needle. And if intravascular injection, that may lead to cauda equina syndrome. So to avoid this, use contrast. And sacral nerve root also can get injured, and sometimes direct trauma can cause sensory loss or bowel bladder dysfunction. Then coming to superior hypogastric plexus block. This is also a rare procedure that we mainly perform for chronic pelvic pain, cancer pain, or visceral lower abdominal syndrome. Exiting L4, L5 nerve root injury lateral to medial needle trajectory may lead to L4 or L5 nerve roots. It depends upon the entry level. So radicular pain, motor weakness, or neuropathic injury may happen with this. L5 S1 disc is another site of entry. So discitis is common here. So transdiscal approach, it is a risk. Then common iliac artery or vein also, there is a risk of bleeding injury, and epidural intrathecal entry also may lead to the same unintended complication. Ureter injury may lead to hematuria, flank pain, or hydronephrosis. Then S1 selective nerve root block, here it is especially for L5 S1 disc prolapse or any radiating pain along the posterior thigh, calf, or heel. So there is a chance of injuring the ventral nerve roots, may injure the anterior branches that lead to motor weakness, sphincter involvement, or neuropathic complication. Dura extending up to S2, S3, so there is a chance of intrathecal injection also. And foramina to pelvic organ, sacral foramina forms a tunnel from posterior to anterior pelvis. So a misdirected needle may lead to enter into the pelvic viscera, especially rectum, and retroperitoneal infection, abscess, and epidural contamination is common. So periosteum injury lead to very severe pain because periosteum is very painful. Sacroiliac joint infection injection, it is the most common but one of the most misunderstood source of low back pain, pelvic pain, this is very common, sacroiliac joint pain. And here sciatic nerve lies caudal and lateral to the SI joint. So if local anesthesia will drag down outside the joint capsule, it can cause transient lower limb weakness, numbness, and iatrogenic neuropathy because due to injury of the sciatic nerve. So intra-articularly, you confirm dye 0.5 ml and avoid excess volume. 3 ml is usually sufficient. And posterior sacral foramina, a needle if placed too medially may enter the posterior sacral foramen. That will lead to epidural spread or anterior nerve root block. And even subarachnoid injection is rare cases. So always use AP and oblique view. A contralateral oblique we may need, and lateral view also check for the spread of the dye. And usually what happens in elderly patients or osteoporotic patient, periosteum is soft. So needle may misdirect and can easily enter into the joint, also bone marrow. That will increase the risk of osteomyelitis, hematoma, and persistent post-procedural pain also. And intraosseous injection, if we are giving, then deep pain, flushing, even sometimes systemic symptom due to steroid injection happens. So for management of this, we can sciatic nerve block, self-resolving. We have to observe and reassure the patient. These are transient symptom. Intraosseous injection, eyes and cells, consider beef steroid taper. Epidural spread, monitor vitals. We need to be supportive care. Infection, same treatment. Hematoma, imaging and monitor hemoglobin, conservative surgery treatment. And for spinal cord ischemia, already discussed, discitis, epidural spread, major vessel injury, everything same. And these are few common complications. Infection is common, bleeding, post-procedure pain, vasovagal reaction, and allergic reaction. These are very common, rare if we use proper precaution. So thank you so much. I think we are already late because this is a very big topic and vast topic.
Thank you, ma'am. Thank you so much for such a comprehensive presentation. I know that it is really difficult to talk so many complications in one presentation, but you have covered it very nicely. At least I got my fellowship things completely revised. There are few questions that I would like to proceed with, if you are okay with the answering question and answer session. Can I?
Yes, madam. Yes, sure, please.
So Dr. Chandrakant has asked that, ma'am, how do you confirm the needle tip in USG guided cervical ESI, whether the needle tip is in the epidural space or not? And the other part of the question is when the symptoms of discitis begins after the procedure, and how do you manage discitis? Pardon me, I have a 4-month-old baby with me.
Okay, ma'am. So, yes, Dr. Chandrika, cervical epidural steroid injection, we cannot give under ultrasound guidance. We always follow the CRM guidance because fluoro guidance, we can see the dye spread. Ultrasound guidance, we can't see. For if you are doing ultrasound guidance, then you can go for a selective nerve root block if there is any radiculopathy. And symptoms of discitis is like post-procedure patient will present you with a very severe low back pain. And even that, I can say it is not controlled by any analgesics, it's very severe. So discitis, you can diagnose it from the MRI or other tests like blood test, or you can see it. And after the procedure, you will manage discitis with high dose of high antibiotic dose, and sometimes you may need surgery. And here we can't manage this at our level. We have to send this patient to the neurosurgeon.
Next question is, somebody is asking, I don't know the name of the person, if you can tell any preservative-free dexamethasone, is it available in India? I know that is a very big problem in our physiatric community, that we are not aware of the drugs and brand names. So if you can help out.
Okay, madam. Dexamethasone, I think it's methyl paraben is a preservative used for local anesthesia, not dexamethasone. Dexamethasone soluble steroid is okay. You want me to name
The
the
question,
brand name.
the question is for the brand name only, so
Okay,
that
okay. I am typing.
that would be good. Actually,
Okay,
ma'am,
ma'am.
there is a question that I would like to ask,
Yes,
basically.
ma'am.
So,
Please, ma'am. Tell.
uh, so you told me that in subdural puncture in cervical epidural injections are quite common. Matlab, as a complication wise, quite common, but
Yes,
it has a very late presentation. So I would
late
like to know that.
presentation.
Right. So I would like to know till what time we should be keep the patient in observation after injecting, so that we can safely discharge the patient by just ruling out that there is no subdural puncture as of now. And what is the maximum time I should be keeping that patient in observation?
Okay, madam, we are having this procedural or daycare basis, so we can at least if we are doing this kind of procedure, 12 hours I recommend. At
Okay.
least 12
Okay.
hours of observations.
Yes. That would be very nice. Another thing,
Yes,
ma'am,
ma'am.
that I would like to ask on the
Yes,
behalf
ma'am.
of our community that
Yes,
you
ma'am.
mentioned some antiseptic nasal spray in SPG block that you keep in handy to prescribe to
Yes,
the patient. So
yes,
can you
yes.
name some? You can provide answers so that we can use it also if
Okay, ma'am.
needed.
I think I have. Oh, okay. I will write that also.
That would be very good.
Okay, ma'am. Okay.
There is one question from Dr. Debashish is like how to prevent common complications during lumbar facet joint injection in USG guided way.
USG guidance, it is, I really like nowadays, I'm even practicing, ma'am. This Dr. Devas asked a very good question, in fact. And ultrasound, like we use the curvilinear probe. And when we put this probe, we use hybrid technique. First, introduce your needle under ultrasound guidance. You can easily see the median branch, and you can see the facets also, the junction of superior articular SAP and IAP gap that can be seen very nicely under ultrasound guidance. Then you put it, then check it under fluoroscopy guidance, and
Okay.
we
The
can go for
hybrid mode obviously brings a lot of assurance
yes,
to us that we are doing it
yes,
right way. I
ma'am.
hope the answer is given. There are not much questions as of now. I think you have done
Okay,
a
ma'am.
wonderful presentations, cleared everyone's doubt. If
Thank you so much.
anyone coming up with any questions, let us hit fast. I can
Ma'am,
go.
antibiotic nasal spray you told, na?
Ma'am, if you can
Okay.
provide us a
Dexona
name.
I'm using personally. That's why I wrote it.
Okay.
And nasal spray, usually this is what we do, like some ointment or thing like mupirocin ointment. We make a swab and put it
Huh.
inside.
Okay.
But
There is
sprays are also not always
so, ma'am,
available.
in that epic test is that you said that it can be a complication, but you use oxymetazoline, xylometazoline as well can be used
Yes,
both
ma'am. Yes, both can be used.
because it usually
Any
is
vaso.
over the counter drug for that nasal congestion only. That you have to pack it
Yes.
or just spray it once and leave it.
Before the procedure, we have to spray once and leave it. And after
Okay.
the procedure, also we can
And
use once.
ma'am, another question, in most of the procedures, you told us that we can encounter a lot of infections. So the thing is that as a regular practice, also we are not providing people with that one go antibiotic shot before the procedure. Do you think
Right.
in your practice that you give
Mhm. In my
one
practice, ma'am, before shifting to OT, I always use antibiotic, prophylactic antibiotic IV shot, one dose.
one dose, that standing dose that you
Ceftriaxone, sulbactam, anything, IV dose, I used to give them. Test dose, then antibiotic injection. After that, I used to shift them to OT.
okay. There is another thank you message for you that I will read, that you have covered them
Yes.
all very well, that I told earlier also. I don't
Thank
think
you,
so we
ma'am.
have further questions. If any questions come up, we will definitely reach out to you, and you had such a wonderful extensive presentation. I'm very happy
Thank
from
you,
our
ma'am. Thank you
community
so
that we
much.
have learned a lot.
Thank you so much. I'm also grateful to all of you for giving me this opportunity, especially Dr. Debastis.
Yes,
Yes,
definitely we'll convey that. Thank you. With
thank
that,
you.
I think we can wrap up. Dr. Ambir sir.
Yes, ma'am. Yes. Yes.
Okay. Thank you so much, ma'am. Good night, ma'am.
Most welcome, ma'am. Good night. Good night, everyone.